morning, ladies and gentlemen. I wish to thank Dr. Joydev and his team for having me here at this wonderful and impressive CME, which has been conducting year after year successfully. Coming to our topic proper, glycosylate hemoglobin. It is formed by the non-enzymatic irreversible reaction between hemoglobin and glucose. And when the concentration of glucose goes up, so will the concentration of glycosylate hemoglobin. It is used as a popular measure of index of diabetic control based on the assumption that the quantity and quality of hemoglobin is constant and the lifespan of glycosylate hemoglobin is fixed. But medicine is not an exact science, and therein lies a discordance in medical practice. Let us listen to the wisdom of our speaker, Dr. Sanjiv Shah, on the nuances of glycosylate hemoglobin. Dr. Sanjiv Shah, the podium is all yours for the next 18 minutes.
Thank you, Chairperson. At the beginning, I would thank Dr. Jyoti Dev and the scientific team for giving me an opportunity to share my thinking on a couple of topics right now here and then subsequently on thyroid in the next hall and then also in the evening. Now, the question here is when we monitor on long-term basis for a lifetime disorder, what kind of blood glucose monitoring? We, most of the time in practice of diabetes, are glucose-centric, and our focus is on glucose level. And traditionally, patients are used to doing once in a while, once in a month, once in a quarter, blood glucose test in the laboratory. Self-monitoring has not become as popular like in West, where patient just cannot be managed without self-monitoring. Those physicians who practice in West. And over the years, the price of a strip compared to a laboratory value of blood glucose has remained on the lower side. I recall my practice when the strip was costing 20 and the laboratory was charging 20. In the city of Mumbai, most laboratories charge between 60 and 80 rupees for a single blood test of glucose, while the strip cost is still less than 20 rupees. And when people do it once in 2-3 months, probably at a reasonably low price, we will have more self-monitoring, which will give us more information. Now, this was always a debate. We also evolved over the years from unreliable laboratory value of HBA1C. The most of the part in the world had been still debating on what is the best method, what's the accuracy. As a researcher for 15 years in clinical trial, we have seen that test done in a global laboratory in a research patient in 2 different laboratories in Singapore and Europe will give us a value which is different by about 0.8 to 1% with just 6 days difference, time difference of just a week. And I wonder that 0.4% is actually considered 2 times coefficient of variation for A1C, which is an acceptable difference between 2 labs or 2 times the test is being done. With kind of an issues on laboratory values, now what is going to help me? There are 2 subsets of patients where A1C just does not help me. Is a patient who has shown serial blood glucose level which are well controlled, and A1C endorses that patient has done well. And you put it aside and then start prescribing looking at blood glucose value. The second group of patient is where blood glucose is high. They were high in the past. Patient may not be following up with a diet or exercise or not receiving adequately effective medicines. And such patients having A1C also 9, 10 or 11. That means patient grossly uncontrolled on a poorly side matching with blood glucose. You still don't give so much importance to either test because they mean the same thing. The difficulties come when you are at in-between level. Blood glucose is different, A1C is different, and they are not matching with each other. And then what is so important when it comes to practice? So let's review quickly what is self-monitoring, what information you get out of it, and what is A1C, and what are the difficulties with A1C. And we'll have a couple of cases to explain what things are. Now, the monitoring basically is done by blood glucose, either in the lab or at home. A1C test, which represents predominantly 2 months of period, 80% contribution come from last 60 days. And there is also in the recent time, little more use of continuous glucose monitoring device or CGMS, which tells you many information much beyond what SMBG can give you in some select patients. In type 1, many insulin treated, multiple doses. The information is great and we do much better with CGMS. A CGMS system from Abbott still can be recommended to large majority of the patients if patients are not at perfect control, and you might see some of the examples there. Wikipedia defines SMBG as something called individual patterns of blood glucose changes. Blood glucose is never static and its dynamic changes throughout the day. There are few meals happening, anywhere minimum 3 and maximum 6 of variable quantity, and Indians eat reasonably diverse on many days, and with kind of food available in major cities, people have a lot of variations on day-to-day basis, and so I'm sure the glucose varies on different days at different level. So you have to design a therapy probably matching with the glycemic excursion. And so self-monitoring ongoing basis makes it a most important tool. I consider if I am connected with the patient, I am treating the patient as blood glucose information is generated in a week or within a week, and you titrate the doses, especially the difficult patients who are trying to come down to near normal, or those who have fluctuations and you have to adjust insulin in such patients. So we need to change the dose of medication, and patient has to obviously self-improve on the diet and exercise, looking at glucose values. Can SMBG become a so-called self-feedback, empowerment, and lifestyle modifier, looking at simply the glucose value? When patient doesn't look at the glucose value, he is trying to believe that he is doing well if he is asymptomatic. And so it is supposed to give probably a positive or a negative feedback and take the action in that direction. So how do we monitor glucose? And this is a graph which is showing blood glucose fluctuation during the day in two different patients having an A1C value of 7.8. On the left, you see reasonably static, and the gray, little ahead of, on the top of a gray zone, which is an ideal range of glucose. On the right, you see the patient having hyperglycemic spike with 3 different meals of the day, and between the meals and at night there is hypoglycemia. Many of these nocturnal hypos are undetected, undiagnosed, and they are picked up on CGMS. That's where CGMS is great. I consider 2 classes of drugs which need titration and which are known to cause hypoglycemia are sulfonylureas and insulins. We have evolved with a newer drugs where there is just no hypo or no dose titration in patients receiving metformin, AGI, pioglitazone, DPP4 inhibitor, SGLT2 inhibitor. 3 drugs, SGLT2, DPP4 and pio, are 1 pill a day, no dose titration. AGI, based on a tolerance and based on the meal, I try to give my patients low-carb breakfast. So I need to use 2 doses of AGI pre-lunch and pre-dinner, and then MET has reasonably fixed dose of 1500 to 2000 milligram. Patients will not need to come to a doctor if uses one of these 4-5 classes of drugs without sulfonylurea, self-monitor, know the glycemic control, and that's where patients are becoming intelligent. Future apps might help them to treat and educate the patient, and diabetes healthcare team may not be so much necessary. I have a practice of 40% patients receiving insulin. They are the difficult one, and plenty of GLP-1. So insulin needs frequent titration, and they just can't be managed without self-monitoring. At the same time, also without A1C. So SMBG is extremely important to monitor, to identify, to prevent hypoglycemia. Hypo is the biggest challenge if you have seen with sulfonylurea over the decades and the kind of insulins we use. In spite of the best insulin like Glargine, Degludec, and analog-based mixtures, we still have plenty of hypos in insulin-treated patients. And so we need to have so-called not any random blood glucose monitoring, There are studies which I have read in the past, and I believed that SMBG doesn't improve glycemic control. And there are still papers on that. And so I didn't recommend SMBG to patients who were receiving oral agent. But then I came across a couple of papers which were called structured monitoring. It's extremely important that you identify the kind of need and the goal for patients who have either prandial hyperglycemias or in between the meal hypoglycemias, and these people would need, or even to confirm that patients who are doing well will need day 1, 2, 3, pre and post meal 6, and this is called 360-degree view, projected and suggested some time back by Roche people, EquiCheck people, and that was called a structured monitoring of blood glucose 3 times a day. Does it help in pregnancy? Yes, it helps in pregnancies, but mild, moderate GDM have reasonably prandial peaks and you want to achieve target. If they are not receiving insulin, there is not so much a need for monitoring. Those who are receiving metformin and diet exercise could be managed without even self-monitoring and frequent lab tests. A1C again doesn't help those patients who are in GDM who are to be managed for a short period of time. But all those type 2 and type 1 running into pregnancy right from pre-pregnancy time onwards need much more frequent A1C, not 3 monthly, but even 2 monthly or at 6 weekly A1C along with SMBG required to titrate the doses of medication. So in short, value of SMBG is great, and that increases awareness of a patient, improves lifestyle, modify therapeutic protocol. What are the difficulties with A1C? As I earlier mentioned about so-called lab-related issues, but doesn't help or does not diagnose glycemic variability. It's a mean and an average over a period of time, and most readings, if they are near normal, you are likely to have some of the glycemic excursion being missed out on that. So doesn't take into account short-term glycemic variability, doesn't help in quick decision to be taken looking at the blood glucose when it comes to titration of the doses or adjustment of the doses. So if your patients are in frequent touch, whether visiting clinic or on telemedicine kind of a program which Dr. Jyoti Dev pioneered long time back and has a publication on that which I quote since last 5 years in many of my lecture, and since 3 years I used app-based communication on all insulin treated patients where we look at real-time glucose value on week-to-week basis and adjust their insulin doses medication. The difficulties with A1C are in addition to a life of a red blood cell. So patients who could have hemoglobinopathies or a condition like hemolytic anemia where life of red cell is shortened, or a condition like CKD, A1C may not be as useful as CKD patients at stage 4 and higher will have some degree of anemia. Patients who suffered in our endemic zones in the country with chronic malaria, major blood loss, so the changes in the blood volume happening rapidly or being transfused from outside will also lead to different A1C results, and they will not match. There are certain drugs which could have an influence, though I am not sure how much we are not in the habit of prescribing vitamin C and vitamin E, which might interfere, and the role of B12 deficiency, which is rampant in type 2 diabetic, but I think B12 doesn't interfere as much with anemia. As it comes to the drugs which have been prescribed in many type 2 diabetics, but I considered only antiretroviral drugs which is associated with kind of a diabetes, and those patients may have interference with this class of a drug in A1C estimation. So probably less than 2 to 5% of patients would qualify where drugs and certain other medical conditions would interfere with A1C interpretation. We can leave aside all those things, but most are focused on anemia, life of red cells, certain drugs, and hemoglobinopathies. So these are some of the issues. What about a variation from lab to lab and time to time on A1C? Probably we do not have an easy control. We are emerging into multiple centers taking a point of a care device where it is being done instantly in the clinic. Even my clinics have point of care, and that frequently does not match with laboratory A1C, and we wonder what we are looking at between two different labs, which is our central lab, our point of care, and outside lab, trying to make a sense. And I realize that except assurance to a patient who have less than 7.5 A1C, most of the higher values doesn't help us in taking a right decision every minute when patient is in front of us. As far as diagnosis of diabetes, again there can be a frequent discordant between blood glucose values. I find normal blood glucose values and A1C around 6 and trying to label a patient as pre-diabetic. At the same time, normal blood glucose and an A1C in the range of 6.5, 6.6 and telling the patient that you are diabetic. When it is much above 7, it's quite clear. And this is what one study said, that 47% measured with A1C, while 62% measured with OGTT. But the data can be different in different population with different blood glucose profile. And though the world is moving toward diagnosis of diabetes in type 2, it could be useful if there is no resource constraint and both could be used together. So coming to HBA1C discordant with blood glucose, there are 4 or 5 conditions which are very distinct of hypoglycemia, variability, and fluctuations in insulin-treated patients. This is example of one of the patient, 53-year-old, type 2 diabetic, receiving insulin and metformin. A patient is on basal insulin in a large dose of 46 units at night and A1C of 7.8. Now, having realized that roughly 30-40% of patients on glargine will still not reach the goal, we have to realize that fasting gets normalized but not prandial, and patient needs to get modified into basal plus or use a prandial oral agents or change over to 2 doses of premixes analog base. These are 3 options for patients who have high A1C and a reasonably high dose of basal insulin titrated to 0.5, 0.6 unit per kg body weight. And this is how this patient's 3 days 360-degree view looks like, where you will find on 3 consecutive days postprandial values that are on a higher side. And you find that pre-meal values are on the lower side. So glycemic variability not taken care of and is being identified. Patients on a insulin pump therapy, 7.7. Earlier pre-pump was 8.8, after pump is 7.7. Hypoglycemia identified. This is how the graph looks like, and frequent hypo being corrected from basal bolus to insulin pump and life becoming slightly better. A third patient who was only on oral medication of Januvia, glibenclamide, metformin, also with a small dose of insulin, A1C 9.3, and patient has reasonably high blood glucose. So variability on insulin, this is distinct graph. Patient has high carb meal, high PP, and rest of the time near normal blood glucose. Finally, the 4th patient, which is on multiple dose insulin, type 2 diabetic, 62-year, bad A1C, HbA1C, but as far as blood glucose diary is concerned is normal. 9% A1C, latest was 10%, but blood glucose looking normal. There can be a good A1C but a poor control on self-monitoring. This patient has hemoglobinopathy, hereditary spherocytosis, as I mentioned earlier, has low A1C but diary showing poor control. So probably we rely much more on multiple blood glucose values rather than single A1C. So 360-degree structured view or one single day done every week but more intensively will try to identify both high glucose as excursion and hypoglycemia. Probably that would be an important information for you to titrate the doses of insulin or doses of medication, in addition to preventing hypo and improving lifestyle modification. And this paper showed that a weekly average was better than doing 3 glycated parameters where protein gets. And this has come in a guideline, and I recall a couple of years back with Dr. Jyoti Dev, we wrote a consensus guideline and it's being published on self-monitoring in international peer-reviewed journal. So finally, to conclude, adequate glycemic control has to be achieved in every diabetic patient, but our goal remains on minimum hypoglycemia. And so large majority of the patients will qualify for pre-meal hypoglycemia time self-monitoring to prevent hypo and titrate therapy accordingly. Thank you for your kind attention.
Thank you.
In one of the slides you showed aspirin slightly increases the HbA1C. in high doses, you said. Most of our diabetic patients
But they receive a very low dose.
75 to 150.
75 or 150.
So that hardly rises
will
in
not
HbA1c.
rise.
Thank
Those are used in a larger doses for specific indication in the past.
Thank you.
Large majority of the drugs which are listed are not actually in use at this stage.
Sir, in severe anemia patients with diabetes, how to interpret HbA1c values?
No, in anemia patient you will not be able to, and you might get a lower value, so it is better to rely on a slightly more frequent blood glucose. And most of the time, either it could be an iron deficiency anemia, which does not change the life of a red blood cell. In our country, iron deficiency is much more common. If you have a CKD anemia or hemolytic anemia, it will be a lower value.
So during SMBG, how often to calibrate the glucometer? Practically, how do we advise our patients?
If glucometer not in use will give you reasonably wrong, and it should be once in 6 months, and you have to have a tie-up with a particular company. There are plenty of meters available, but I use predominantly 2 meters, Roche EcuCheck and Johnson's One Touch. Most of the time we have a good rapport with Roche people, and we see to it that all our patients are being attended by company people. Use control solution, Calibrate, but 15% variation is acceptable according to international standard. We relax in our situations at 20%. So 20% has not affected us in many decisions, but we take into account the lower value in order to prevent hypo. With 40% insulin receiving patient, even though we prescribe safe, patients get scared when they get true severe hypoglycemia. More frequently, we suspect that HbA1c value is...
Keep repeating it.
We do not repeat, because repeat results into more controversy and difficult discussion with a patient losing additional money and it being cumbersome. So we go by 3 criteria: severity of diabetes in the recent past in that patient, the kind of medication you have used, and how that whichever is a repeat value is going to change the line of a treatment. So we have to be reasonably good clinician when it comes to not believing any lab value for that matter. When I don't believe some of the values of either blood glucose or even in thyroid functions, we don't believe, lab is not reliable, we don't ask the patient to repeat. Then how do you know that that one is a right laboratory?
Thank you, Dr. Sanjiv Shah, for that enlightening talk. That we conclude the session now. Thank you.